My name is Jessica. I am 34 years old and I was diagnosed with Crohn's disease in 2002. When I was diagnosed with Crohn's disease at 14, fertility and pregnancy were so far from my mind. I just wanted to be a normal teenager. In the first 2 years, I had tried every level of medication that was available, from baseline 5-ASAs to biologics, even low-dose chemotherapy, and nothing worked to put me into remission. At 16, I had my first surgery to remove a foot of my colon, and shortly after that, my medical team found a drug cocktail that did work for me, and I was finally able to achieve remission. Unfortunately, when I was 21, I did something that was really foolish, and I stopped taking my medication. I thought I would be fine. I thought that I would stay in remission, and I did stay in remission for a little while, and then my Crohn's came back with a vengeance. And at this point, the medication that had worked for me before no longer worked because I had built up antibodies to it. I went through trying more medication, even a clinical trial, and I rapidly declined. I was hospitalized every other week due to dehydration and blood loss and weight loss. And eventually I made the decision to have a life-saving surgery, which would take out my colon completely and leave me with an ileostomy. And after that, I had my rectum removed, and my surgeon had told me at the time that the chances of conceiving while healthy were far greater than conceiving with active Crohn's disease. So after my surgeries, I had seen an OBGYN who eventually would diagnose me with hydrosalpinx, which was fluid in my fallopian tubes. And this was likely due to scar tissue or adhesions from all of the abdominal surgeries that I had. I was told it would be difficult to conceive naturally. However, a few months later, we were shocked to find out that we were pregnant with our first child. Because I had exhausted all medical options prior to my colectomy, my medical team and I made the decision to not be on any drug therapies. With regular ileoscopies and follow-up appointments and continued monitoring, we felt comfortable with having the approach of we'll cross that bridge if and when we come to it. During pregnancy, I was considered high risk and had frequent appointments with a maternal fetal medicine OBGYN. And at every appointment, I had ultrasounds to closely monitor the health and growth of my baby. I was also in frequent contact with my IBD specialist and my colorectal surgeon, even my ostomy nurses. Before we made a delivery plan, we all talked together to make sure that we were comfortable and in agreement with what I had wanted. And it was so important to keep the lines of communication open, both for myself and for my baby to stay healthy. From the moment I was diagnosed with Crohn's disease, my parents really made it a point to stress the fact that knowledge is power. And the more you know, and the more you participate in your care, the more in control you are. With both of my children, I ended up with obstructions late in pregnancy. This was mainly due to the baby growing and putting increased pressure on my intestines and my stoma. With my first baby, I also suffered from gestational hypertension and polyhydramnios. I had planned to have a vaginal delivery, which my medical team was completely on board with. However, at 37 weeks, I was induced due to worsening hypertension. And after 17 hours in labor and on an oxytocin drip, my baby became distressed. My OB quickly got on the phone to my colorectal surgeon and asked if he was able to scrub in for cesarean delivery. Without hesitation, he came to the labor and delivery OR. And my OB actually asked my colorectal surgeon to make the cesarean incision. And I thought, That was such a beautiful demonstration of how we had all worked together as a team to make sure this baby made it here safely. Having the outlook of being on a team with all of my doctors, having the same common goal, trusting each other, and having open and honest communication put me and my baby in the best possible position to have the best outcome.
Jessica talks about considerations for fertility and pregnancy. 50% of patients with inflammatory bowel disease are women, and most of them will carry the diagnosis during their reproductive period. It's important to understand what medications will impact fertility and pregnancy and what surgeries will impact fertility and pregnancy. This is a discussion that you should have with your provider and with your gynecologist. There has been a lot of research recently on fertility and pregnancy. The default in the past was either to tell women not to get pregnant or to stop all their medications to get pregnant. Both of those are obviously harmful. We now have adequate safety data on the biologics to show that you can continue them during pregnancy. And if you stop them and you flare, you're actually putting your own health and the health of your infant at greater risk. You can learn more about pregnancy and fertility at the AGA and CCF website, ibdparenthoodproject.org. You should also talk to your doctor and your gynecologist about this. The IBD Parenthood Project put both maternal fetal medicine or obstetric specialists and gastroenterologists on the same page, so we all have the same care pathway for you, and there's no longer disagreement from both sides. It's important to have an interdisciplinary team when you are pregnant and to be followed closely. We recommend that all pregnant women are followed as high risk by a maternal fetal medicine specialist. If you've had complex surgery, your colorectal surgeon should be part of that team, and your child's pediatrician should also understand the medications you're on and the implications to the child.